Okay, so we've talked already about not all, but a lot of the reasons why we can have a slow heartbeat. And I mentioned many times often the treatment is a pacemaker. So let's talk about what a pacemaker does and how we put one in. So here's my diagram again of the heart. And we talked about the two different kinds of slow heartbeats we can have. Let's move on to AV block. Okay, so let's say a patient has a complete severing of the normal electrical connection between the top and bottom chambers of the heart. So they're going to have a normal heartbeat up here, but the pumping chambers are going to be really slow. So we'll say it's 30 beats a minute up here and maybe 60 or 70 up here. So this person is feeling poorly. They're in the emergency room. They don't have a reversible cause, and we elect that we're going to put a pacemaker in. Okay, so what does a pacemaker do? Well, the idea with a pacemaker, if we had something we could just create an electrical bypass across this connection, then that would be great. We could just install that, but we don't have something like that. But a pacemaker effectively is like an in this kind of patient at least, is effectively like an electrical bypass across that block. So here's how it's done. The patients that we put pacemakers in, the way we do them today in a patient like this is called a transvenous permanent pacemaker. And we actually put wires inside the heart. So the heart, recall, is hooked up, the right side of the heart is hooked up to the main veins, the electric or the pumping plumbing system of the heart. And the veins go out here, supply the arm, the head, everywhere else. We can access the veins quite readily, fairly close to the heart up here under the collarbone. So in my patient, imagine his head's up here. Over here is the collarbone. There is a large vein that travels down into the right atrium from, this is a bad diagram, but bear with me, from the shoulder down into the right atrium. And we can access that with a needle and then pass a wire all the way through that vein down into the right atrium. We can cross the valve and then plant it down here into the right ventricle. And this wire, the ones we use, have a little tiny screw on the end of it. And we basically just fish it through the vein, across these structures, using an X-ray to guide us, and then literally screw it into the muscle of the heart. We do the same thing then from up here, through the vein, and then down into the right atrium, and literally screw it into the muscle of the right atrium. So now we have electrical contacts to both of these chambers. Anytime electricity touches metal, if you apply electric charge to it, you can make the muscle squeeze. So we then hook these two wires up to what we call a pulse generator, which is the hunk of metal. It's about the size, I tell my patients, those that are old enough to remember Eisenhower silver dollars, about the size of an Eisenhower silver dollar. And we put that chunk of metal, attach it to the wires, and then slip that underneath the skin. All this is done through an incision about 1.5 inches or so long. It's all done under local anesthesia with a little sedation. We'll actually sometimes talk to patients while we're putting them in. Hopefully they don't remember it afterwards. They're kind of loopy. But it's not a major operation. It's fairly simple and not a lot of discomfort associated with it. Once those wires are in place, then what the device will do is the top wire will essentially listen to the chamber to find out what the heart rate ought to be. So in this case, the top chamber's beating 60 beats a minute. It's working perfectly fine. It'll send that signal back to the little computer that's inside the pulse generator and tell it, hey, we want a heart rate of 60. The pulse generator will then listen essentially to the bottom chamber, and if it doesn't see 60, it knows something's wrong, and it will then fire a signal and deliver a little tiny pulse of electricity that's enough to make the bottom chamber squeeze, and that'll cause the heart down here to squeeze right after the top chamber squeezes, and that'll restore the normal heart rate and the normal sequence of contraction. So you'll take someone who rolls into the emergency room feeling very poorly, may have just fainted, with a very, very slow heart rate. You put these two wires in, hook them up to the device, and then like magic, they're back to normal again. It's pretty remarkable. It's a very satisfying job as a doctor, these patients, because they literally kind of spring right up and look great afterwards. It's a very short recovery, a lot of satisfied patients afterwards. So that's typical pacemaker implantation for a patient with AV block. So let's say we've got a patient who's got a pacemaker in and it's rolling and everything looks good. So how do we maintain that? Well, the pacemaker units run on a battery, and anything with a battery is eventually going to wear out. These devices are very, very efficient. They don't draw a lot of power, and the batteries are very modern and well designed. So most pacemakers are probably going to get us in the vicinity of maybe 8 to 10 years of battery life. You know, and I ask my patients sometimes, can you name another device anywhere in your house that lasts 8 to 10 years that runs on a battery? And I don't think they're even rechargeable. Sometimes we say, well, what about rechargeable batteries? Even your rechargeable devices aren't going to last that long. They'll eventually wear out and be replaced. But pacers work really well, and we sometimes will break 10 years. So we're pretty proud of that. They work, you know, when they work really, really well. Now, are there things that can go wrong? You better believe it. There are things that can go wrong. Thankfully, they're fairly rare, but you know, in 20 years of doing this, I've seen just about everything that can happen. One of the things that we fear the most is an infection of a pacemaker system. This is all sitting inside the bloodstream, underneath the skin, and then these are actually inside the bloodstream. So they're exposed to whatever flows through the body. And anything that's mechanical, artificial inside the body, if it gets infected, the body has a hard time dealing with that and has a hard time curing an infection if it lodges on something artificial. That goes not just for pacemakers, but like artificial knees and hips and things like that. So we can see infections of pacemakers early on from the actual surgery. If the incision line doesn't heal well, if something gets into the bacteria gets into the incision somewhere along the line, then that can certainly cause an acute infection. And those aren't good and those are bad. Sometimes we have to remove those. Worse, however, would be if it got infected many years later. If that happens, it's usually because it got seeded from somewhere else in the body. A bacteria might get on one of the wires, and then we have to remove things. And they're harder to get out when they get older. Now, thankfully, that stuff happens very, very infrequently, and we know how to take care of it. We can treat all those things, but those are one of the downsides to having a pacer. Wires can fall out of position. As I said before, there's a little tiny screw on the end of the wire that holds it in position. That doesn't happen very often, but if it does, we'll have to go back and replace them. Generally, if they stay in for the first 24 hours or so, they're going to stay in for the long haul. So dislodgement is generally something we'll pick up in the hospital on the initial admission. And it happens maybe 1 in 20 or less. Wires can break. These things are in the body. They're essentially doing kind of the paperclip thing, flexing back and forth, especially up here in the arm where people move. And over time, the wires can break. That's maybe 1 in every 100 after about 5 years. If a wire breaks, it may malfunction. It may shut down completely what it does. More often, it sends us interference or electrical static and such that we can pick up in the device, and then we can address it before anything bad happens. So that's a rare complication of pacemaker systems, but one we can also deal with.